Welcome to Critical Choices, a podcast from the American Academy of Emergency Medicine Ethics Committee, where we explore pivotal ethical decisions in emergency medicine. I'm your host, Melissa Myers, and today we're diving into really a foundational question when we talk about ethics, which is, can ethics be taught in medical school, or is it something learned only through experience, mentorship, and the hidden curriculum? I'm an associate professor of emergency medicine, and I do wish to read the following disclaimer. The opinions and assertions expressed herein are those of myself and do not reflect the official policy or position of the Uniformed Services University of the Health Sciences or the Department of Defense. I'm excited about our guest today, Dr. Patricia Bayless. She is an emergency medicine physician as well as the Chief Wellness Officer at District Medical Group and a clinical associate professor at the University of Arizona College of Medicine, Phoenix, and assistant professor at Creighton University. You have a lot of titles, Dr. Bayless. Dr. Bayless has served nearly 2 decades on the ethics committee at ValueWise Health and is president of the Arizona Bioethics Network. Welcome.
Why, thank you, Melissa. I'm so excited to be here.
I'm excited to have you. So, we have a couple of really interesting articles to discuss today, and I'd like to start briefly with the first that you sent, The Inescapable Relevance of Bioethics for the Practicing Clinician. And I think that this article really speaks to the importance of taking time for ethics education during undergraduate medical education or UME. It can be really hard to make the case for taking time away from the quote harder topics like, say, cardiovascular physiology. With that said, the article discusses the gap between what widely accepted ethical norms and current practice. For example, we all know that we're ethically obligated to disclose medical errors, but when you look at the actual disclosure rate, it is relatively low. So, my question for you is, can you discuss why you consider ethics to be an important part of undergraduate medical education?
Thank you. I've struggled with this for a while after I started delving into ethics as the chair of the ethics committee. And what I was concerned about is that there is no true curriculum for teaching ethics beyond saying everybody memorize the four principles of biomedical ethics, which are fine, except that what we have to explicitly understand or reveal how those actually are practiced by those clinicians working at the bedside, and how did they get to that? Because until recently, we talked a little bit about what mentorship is and how we tend to, as learners, mimic behaviors that we observe. And we know that some of those behaviors are good slash professional slash ethical slash moral, and some of them aren't. And so giving learners an opportunity to evaluate those behaviors and, if possible, make them part of their own internal moral landscape, because we know that everyone comes to medical school with some sort of personality or innate philosophical or moral sort of background, their whatever their value system is. And so we find, and I think we'll talk about this a little bit later, that during undergrad and graduate medical education, sometimes our own internal systems are challenged, and it's accepted that you might not necessarily change them, but find yourself in a situation where that's not what you expected by the time you completed your training. And then when we have folks out in practice, the article I think was interesting because in practice, we find that it's also implemented by the clinicians in an uneven sort of way. And we're trying to understand why that is and how can we improve that, because there's two things. There's the what's inside of you, whatever your compass is, but then we also expect professional behavior. And those behaviors stem from the biomedical or the bioethical principles, but also there's no real way to learn them except through practice. And that may not be the best, because if you don't have a good role model, if you will. And to speak to what we call the curriculum, the hidden curriculum, is that's where the curriculum has been. And we need to explicitly appreciate that and see if there's a way we can improve that hidden curriculum, if you will, or make it more externalized so people understand where they're coming from and where they might be going to.
Yeah, I thought one of the interesting takeaways I found in the article was we would all like to think that we're moral agents and that when presented with a moral crisis, we'll act in what we would consider to be the appropriate way. And sometimes these ethical principles, they look so simple on paper, and yet will act in a way that's contrary. So the example from the article I thought was really good was when the Nuremberg Code came out, there's a quote in here from an American physician saying that it's unnecessary for any good physician, is the exact quote. Obviously, we would never do anything that's discussed in the Nuremberg Code. And of course, one of the things discussed in the code is experimenting on patients who haven't consented to the trial. And this is 20 years before Tuskegee. So obviously, I think maybe it was necessary. And maybe if it had been studied a little bit more, we wouldn't have had these unethical trials later on.
Sure. And I also think it has application as we move forward into the brave new world of the disruption in medicine that we see with the tools that are coming, that they truly need to be evaluated as to what is their value to both the clinicians and to the patients. And we need a framework to walk through that discussion. And that is one of my chief goals as I interact with students and residents and sometimes my colleagues. How do we make these decisions? How do we walk through this? And the discussion we would be incomplete without mentioning my hero, Dr. Edmund Pellegrino, who wrote widely on what he called virtue ethics. He was a practicing internist at Georgetown, and he's very well regarded and very well written. We've written quite a bit on how we can work through these sorts of topics because there's going to be ethical decisions in the future that we don't even know about what they're going to be about, right? Because the technology is constantly in flux.
And that almost leads us into a point that we're supposed to hit later, but it's such a good lead in, I have to mention it now, which is if we teach our undergraduate and our graduate medical education students a good framework, they can address these questions of the future that we can't even anticipate. I was teaching recently about evacuation during the Civil War, and it was interesting how some of the frameworks around the ethics of evacuation then could be applied to very current topics like in 20 years, if we have an autonomous vehicle that we are evacuating patients on, what is the ethics of automating evacuation? And
Mhm.
we're looking back to 1860 to come up with a framework for some of these ethical questions. And so it's fascinating to me how developing that framework can be applied in so many different areas.
Right. That's why there needs to be a process. There needs to be a way to think about these that accounts for both the thinker, the clinician, what is their own personal landscape or value system, recognizing, first of all, what theirs is, what you have inside of you. And then, second of all, appreciating that not everyone is going to have the same sort of value system or consider how to move forward, or that even your actions are in fact ethical. And so there needs to be a way to both say those things explicitly and be allowed to discuss them in a respectful way that would bring everyone to the table and make it so that it's acceptable. I know I'm also gonna jump ahead. I was just rereading the hidden curriculum again and how we think in medicine that what we do is just all about the facts, just the facts, ma'am. However, they exist in a cultural and a sociocultural environment, and how those facts can be applied or interpreted may be open to discussion, and that it is not when we practice, it is not a value neutral proposition, that there are other things that could influence that. It's not clearly fact A or fact B.
Leaving aside the fact that I think a lot of the ethical decisions we wrestle with in, say, emergency medicine, it's not a fact-based decision. I think end of life care comes down to the values of the patient. And I'm going to ask you in a second what your ethics teaching looks like. I know when I've worked with undergraduate medical education, a lot of what we end up talking about is what to do, where the ethical dilemmas lie when your values differ from your patient values, and when, if any, are there times that you're obligated to override the patient. So, with that, I know that you teach ethics, and I'd like to hear a little bit about what that looks like. What's in your curriculum? What does it look like?
I won't take credit for the curriculum that we use at Creighton, which happens to be where I've been involved for the last several years. They have a first and second year, a class that continues through the first and second year, where they try to consider what they have practiced as ethical dilemmas and also trying to invoke more humanities types of a curriculum as well. Because the reason why we have these conflicts is because they're conflicts between humans and their values, right? And so, how do you allow people to bring those to the table? And one of the chief skills that you have to learn, I think, to do this to follow an ethical practice is to learn how to listen to what other people's values are and identify that humanity or the commonalities that will allow you to come together to bring forward the best decisions that the patient can make or perhaps their surrogates. And also that applies to the bigger world, right? Because we know we don't practice in a vacuum, that there are competing interests, for example, financial interests or legal interests that also do impact those decision processes that we need to consider.
So, what kind of frameworks do you teach to your students? Do you have a way that you break cases down with them? And can you walk us through that?
Yeah, I think this particular field lends itself very well to an interactive discussion. And I think the first thing that you do, at least what we can do in a case, is provide a basic framework of the name, the age, what the medical disease is, and then where we are going to go, and ask the students to say to evaluate where are their values in that discussion, where can they see someone else's point of view, and then also to appreciate how, if you introduce another variable, how would this change the decision? Because, for instance, in emergency medicine, someone comes in with chest pain, but it's an undifferentiated complaint, right? Suddenly you have to know more about who are they, what are their other issues. And so the same thing happens in a case that, say, an end of life case, someone has a terminal illness and you know that they're not going to recover. So, what would you recommend to this patient regarding do not resuscitate status? And then you ask the question, what is your goal? You know, that I know you have a terminal disease. How can we make you comfortable? Or what do you need to accomplish in the time that you have left? And unless you learn to ask these questions, and it is one of those being comfortable with the discomfort,
Mm,
that question.
yeah, absolutely. I know every time I've taught ethics, especially in the kind of the graduate or undergraduate medical education realm, the hardest part is explaining that there's not a right answer. I can give you my answer, but that doesn't mean it's the only answer. It's definitely not the only answer. And there's often not a right answer.
Right, and there's no p-value here.
It's so frustrating.
There's no area under the curve, I'm sorry. And particularly in emergency medicine, and it's true in all of medicine, that we can't always predict the outcome, even though this should work, it doesn't. Or you're sure it won't work, and what the heck, it does. So being comfortable with that discomfort or unknown is very important for all folks in medicine. And then it's amplified in emergency medicine because of really the time constraints and our general lack of knowledge about the patient themselves, because they come in as blank slate and our job is to find out the information really.
Speaking of finding out the information, one of the ways that we work with our students here to help them break the cases down is we teach them several different approaches. We use either the 4 box method, where it's 4 boxes and you write down information from the patient's perspective, the clinician's perspective, the standard of care, and then like potential outcomes. And it helps you. We I rather like it. I find it very useful with the students because it makes you ask all the questions. You sit there and you ask, what are the patient's values? What are the ethical principles at play? And it walks you through. I really enjoy doing that one with the students. A lot of my students really prefer to use a principlism approach. So the classic autonomy, beneficence, maleficence, justice, with the caveat that often it's hard to figure out how to apply justice to an individual case. So they leave that one blank sometimes. And I feel like there's stuff that goes in that box too. So I'm curious to know what you use. I know when I analyze cases myself, I'm a deontologist at heart, so I will always start ranking things in terms of rights and duties towards patients. But I have not found that to be a particularly helpful approach with students because they don't, especially as undergraduate medical students, they don't yet have that full professional identity formation to help them understand what are my rights and what are my duties in this situation.
Yeah, that's an interesting question. Most of those we try to format right ahead of time and ask questions specifically about how would you approach this as the patient, trying to have them walk in someone else's shoes, have another point of view beyond just the fact finding mission that we encourage with history and physical, but also really it becomes having the cases described, both to ask the questions ahead of time, allow them some opportunity to consider, oh, well, that does change how that would happen by having at least a different perspective on things. So it's most of the time trying to ask them, how did you come to that decision as well? And the fact that you're using, I think this really lends itself to case-based discussions, and it's easier in smaller group discussions, obviously, because it allows people to speak up, which they wouldn't in necessarily a larger group. And most people are more comfortable in the smaller group trying to speak up. Yeah, I think you do have to spend some time constructing the cases, and let the case try to illustrate what the principle is that you're trying to bring them to, rather than starting with the principle, because that just is too abstract.
Yes, I completely agree. I know when I was doing the reading for my master's in ethics, I had the hardest time in the earlier courses because they were very abstract and philosophy based, and the more clinical it got, the easier it got.
Yeah.
So the follow-up question for that is in your ethics small groups, are there any kind of items that you draw a hard line for? So I know when I'm teaching, I have a red line of if you answer the question by saying, I feel that, I'll make them back up. I understand that you feel that way, and you might feel that way for valid reasons, but you got to explain the reasons to me, right? Like, I feel that this is the correct answer. No, I want to hear, I'm going to prioritize autonomy in this case over justice for X, Y, and Z reasons. And I'm wondering if you have any similar kind of hard stops.
As I consider what you just said, yes, I know that's how I tend to direct the conversation. And just starting out, even up front, sometimes introducing a case, it's ethics is not about feelings. It's about what do we know? How can we use that information to manage patients and their families and their values in a way that is both sound scientifically, but also appropriate to where they are in their life. And so I don't know that I have a hard word, but I would say I do tend to interrupt with that kind of if someone started with that sort of a conversation.
Which is hard. I know that the cases we use tend to evoke very strong feelings in the students. And so it's recognizing those
Yeah.
feelings and then,
Yeah. In fact, when they start, particularly at Creighton, I know they tend to introduce the cases as well as saying, some of you might feel triggered. So they use
mhm.
that kind of a language to allow people then to actually opt out if they need to, right? Because some things are very overwhelming, even from a personal perspective. But then to come back around after that and work with the student as to why this was something they maybe had to withdraw from a discussion for because they need that care as well.
Completely agree. So I want to come back to the idea of the hidden curriculum. So we've talked about what ethics education might look like in you and me, and a little bit about the importance. It teaches us how to approach the dilemmas, how to recognize when the dilemmas are present. I've found, interestingly, some of the cases they'll tell me there is no ethical dilemma present. And we'll have to circle back and say, no, there's actually a significant dilemma here. Let's talk about what it is and how we got here. So recognizing that when there's an ethical dilemma and then having a framework for approaching it. Obviously, I'm biased here. I think that's very important to teach a medical student or a resident, but not everyone agrees. And that one of the articles you sent me talks about how the hidden curriculum is so strong, right? What the students pick up by osmosis on their rotations, what
Mhm.
residents pick up, that
Mhm.
there's almost no point in ethics education earlier because it's just going to get overwhelmed by the hidden curriculum. Now, I was wondering what your comments were on that.
I'm obviously going to disagree.
Right.
That, there's no way for us to intervene earlier if we're not asking about it or talking about it. And 100 years ago, when this was clearly an apprenticeship model, and you really only could learn what the person teaching you could teach you, for better and for worse, that we're just not in that sort of a setting anymore, and that we should take advantage of that. And when you said that, I went back and looked at a couple things and how even institutions just assume that the doctors will take care of it. They'll do the right thing. And it's, we need to talk about this because sometimes you have not provided us the tools to do that. Where are the gaps for us to be able to meet the ethical or professional standards that we set for ourselves? Because to do less than that and not have the institutions on board and the medical school deans and those on board, it's just not going to change. And it's to our detriment if we're not able to meet these challenges.
In a crisis, you don't rise to the crisis, you fall to the level of your training. And I think about that a lot with ethics, because if we aren't training you in ethics at all, then what training are you falling back on? You're not.
Right.
You're acting instinctually, and acting instinctually leaves us open to our own biases or assumptions.
Yeah.
Whereas if we're teaching people to recognize and respond to these crises, they're more likely to respond in a manner that they want to respond.
Sure, to be able to even address these questions and help others. And the other thing is helping others recognize them. Maybe the CEO of your hospital doesn't think it's a big deal if they cut out this service, but then how do you advocate for that if you don't see it as a really important issue and, in fact, an ethical decision to eliminate a service in a
Mhm.
hospital system? These are the magnitude, and that's not obviously for the student, the undergraduate student to address, but maybe at the residency level and clearly at the attending level. And we need to feel like we have that education and that necessity to be able to meet our professional obligations.
So speaking of residency, we talked so far about undergraduate medical education, so medical students. And I want to briefly touch on residency requirements, specifically for emergency medicine. And I went before this and looked up what are the ACGME EM residency requirements in this area. And it's fairly short. It says programs in partnership with their sponsoring institution must educate residents and faculty members concerning their professional and ethical obligations, including but not limited their obligation to be appropriately rested and fit. That is very broad, not particularly specific, no milestones there.
And we laugh, right, when it, particularly the very last part of it, when it says you should address your sleep and your hygiene. And that's like, maybe. But
You
yeah,
probably
so
should. I don't know if that would really fall under your ethics milestones, but it's not wrong to be
right.
rested when you come to shift.
If you think about it, all of those issues, now, obviously, that leaves a very broad swath. And I, at one point, queried the residency directors at Valleywise, where I was working when I was chairing the committee. And so, how do you address this with your residents? And the responses went pretty much from zero to, yeah, we have a few lectures. And for better or for worse, these ethical and moral type issues do underpin the professional behavior issues so that even if you're not sure that your student or your resident has the same internal compass that you would like to see, you can certainly teach them to behave in a way that is appropriate to the profession.
And I think it's interesting that this isn't more stressed specifically in emergency medicine because we have no time. I think it's interesting. I've gone to and I've given some ethics lectures now for internal medicine residencies or family medicine.
Yeah,
And they tend to heavily stress consulting an ethics committee or you having a family meeting. And it's very interesting because when I hear these lectures, I think, yes, that makes great sense. If you have an ethics committee at your hospital and you want to involve them, by all means, bring in the experts. And they'll
right,
ask me, when's the last time you consulted an ethics committee? I'm like, literally never. First of all, I work night shift. So the fact that there's no ethics committee is going to come to my hospital at 2 a.m. And then secondly, the response time is, I think it's 24 business hours most places, which is not unreasonable,
right.
absolutely not helpful to me in the ED. So it's interesting to me that we don't stress this more with our residents because we don't have the safety valve that a lot of other specialties do.
Yeah, and that safety valve is time. And then I think also one of the ways we could address that is we tend to look back at some of the cases and maybe we shouldn't always focus on the actual root cause analysis sorts of things, but try to discuss more how the decision making was done because that does affect how you might proceed with a patient given the limited information that we tend to have in the time that we have to see a patient and make a decision about medical care. I know it's not really part of the discussion we wanted to have, but this is one of the difficulties, like with capacity, determining capacity in a patient and deciding when you can trust them to be making decisions about their medical procedures and when you should maybe try to reach out or to a colleague or their family or someone else to make those decisions. But that is a really difficult topic, probably one for another one of your podcasts. But you can see how that becomes an issue. And I agree with you that the time is truly a difficult barrier in trying to make appropriate decisions. The other thing I can say is that sometimes when we don't have enough information, gosh, do we intubate this patient or not? Where's their DNR form, et cetera? It's not ideal, right? That sometimes we end up doing the default and saying we can always withhold or withdraw later, right? But sometimes you have to look at what the ultimate outcome is going to be. And if the ultimate outcome is 6 feet under, you're going to take a little more care in how you proceed, even in that moment.
Which gets us back to the hidden curriculum. And I think the way that I would look at this is yes, the hidden curriculum is there, and we can't overestimate the importance. The students and our residents draw so much from the hidden curriculum. But that doesn't change the fact that we can offer them these very objective frameworks and ways to recognize and respond to these dilemmas. And it's worth doing that, even knowing that it's going to come up against pressure.
And also preferring to be in a residency education and undergraduate education setting, making a point. We always talk about teaching at the bedside, and this is the supreme example of when you should have these discussions with your learners as you obviously step away from the bedside sometimes. Afterwards, you're sitting in the quote unquote doc area and really need to be talking about this with a cup of coffee and bringing in the other folks that were there that day to have those discussions. There's lots of opportunities for informal teaching. I would not say this is hidden. We need to be explicit about why we're bringing these topics up.
Yeah. So as we start drawing towards a conclusion, I wanted to mention some of the concluding recommendations from this 1994 article. And the article is by Happerty et al. It's the hidden curriculum, ethics teaching, the structure of medical education. Because these are 30-year-old recommendations that I think are very applicable for today. And it's recommendation one is listen to concerns from the students, particularly those from backgrounds not well represented in medicine.
Sure.
Recommendation two is attempt to make the hidden curriculum explicit and determine what students are learning from the hidden curriculum. And recommendation three is all faculty, not just clinical, must be willing and able to identify and discuss ethical dilemmas with students. And recommendation four is students need to given the opportunity to learn about the impact of ethics at an organizational level. And
Mhm.
I think these are great. These are great recommendations.
Yeah. They have not degraded at all over time. And in fact, slowly, I think we see some of them being offered by trying to have time dedicated within the what we call the didactics to spend some time in these areas. I'm going to add there also including wellness stuff in
Mhm.
those sorts of discussions as well. But it is important that we understand the point of view, right? Not just our own, but what other people experience and why that impacts their decision making. Because I like to say, the residents probably and the students get tired of me saying that you don't know until you ask. You just don't know. You can't assume. We know what that stands for, but we just don't know. There's things I just don't know. And I'll tell you what, these days we practice in some ways. We don't have to travel to practice in cultures. I can tell you in any given shift, I take care of family from Somalia. I take care of another family from South America. You have a patient who does not speak English. Oh, wait, they only speak Romanian. And oh, by the way, before all the great translating services, it just happened that we had an OBGYN resident who spoke Romanian. This is not a an impractical sort of thing to bring to the bedside. These we just don't know. We need to learn more. We need to be open to that.
Thank you so much for sharing your perspective, Dr. Bayless. As we conclude, I'd like to ask, do you have one thing you would like people teaching ethics, particularly at the undergraduate medical education level, to take away from this?
I guess the most important thing is to spend the time and help the students recognize if you want to talk about hidden curriculums, you want them to recognize that these are not hidden, that these are really important issues, and that they are going to be called on to use their skills as they go forward in their practices.
Thank you, Dr. Bayless. I'm Melissa Myers. This has been Critical Choices, a podcast from the American Academy of Emergency Medicine Ethics section, and thank you for listening.
We hope you have enjoyed this podcast from the American Academy of Emergency Medicine. AAEM is a nonprofit professional association of over 8,000 emergency physicians dedicated to board certification in democratic group practice. For more information about AAEM, visit our website at www.aaem.org.